Good morning, ladies and gentlemen. Warmly invite you to the fifth day of the biggest implantology event of 2020, the world's first virtual dental implant expo organized by DentistChannel.Online. My name is Ruben Lobo, and I am very excited, delighted to have you all as our beautiful participants for this session. Ladies and gentlemen, today we have with us Dr. Shallen Verma, a person who's doing a remarkable job in the field of implant dentistry as well as in all the general dentistry aspects. A short introduction about our speaker. Dr. Shallen Verma is a specialist dentist, periodontist, and an implantologist who has over 24 years of experience. He was in the panel of doctors responsible for providing dental care to the Prime Minister and the President of India. He was awarded as the Distinguished Medical Specialist in Individual Specialist category in the Health Awards 2018, held under the auspices of Dubai Health Authority as well as the Tumbe Group. He was conferred with the Most Loved Dentist Award for the year 2010 in the whole of UAE and the MENA, that is the Middle Eastern and the North African regions. He has specialized training in implants from Germany and Brazil, and also specializes in implantology, bone grafting, and plastic periodontal surgery with a special interest in TMD cases and laser-assisted dental procedures. He also specializes in laser-assisted dental procedures from Germany. He is having a diploma in orthodontics from the International College of Neuromuscular Orthodontics and Nathology based in Italy. He has done an MBA in Healthcare Services from the Sikkim Manipal University. He has vast experience in general dentistry as well as is well versed with all aspects of dentistry. He has done many scientific presentations and contributes regularly to scientific journals and writes articles in various magazines. Ladies and gentlemen, presenting to you Dr. Shallen Verma live on the topic, Management of Implant-Related Complications Using Technology. Ladies and gentlemen, Dr. Shallen Verma.
Hi, good morning, good afternoon, good evening to all of the wonderful listeners who are so enthusiastic about learning. And at the outset, I would like to thank Ruben and the Dentist Channel for doing such a wonderful job in giving us so much education and getting us to learn so many things. So greetings from Dubai. It's morning time here, 10 o'clock in Dubai. And today I'm going to talk about the management of implant related complications using technology. Now, implants, as you know, are the order of the day because so many implants are being put all over the world. And this is the technology, this is the one of the service which is being used by all over the dentists all over the world. And now considering the number of the implants which are being put all over, it is anticipated that some kind of complications would arise pertaining a lot to the implants. Now, I'll touch basically on the two topics today primarily, which is the occlusion related problems and the peri-implantitis. So my presentation would be divided into how to manage the occlusion related problems and the peri-implantitis. So first of all, I would begin my presentation with a very famous statement from Dr. Gordon Christiansen, which says that observation of occlusion and treatment of occlusal conditions is very sadly neglected in our profession, and I feel it's pretty true. Now, there is another statement which says the concept of collateral damage, that is problem in one of the masticatory systems, like for example, problem in occlusion or joints or muscle will actually have a spiral effect on the other system and vice versa. And another important statement which says that occlusal disease is the most common dental disorder and unfortunately the most undiagnosed dental disorder. So I'll begin my presentation again with a case study Now, I would like to all of you to have a look at this case. Now, this is the case which came to me just about 10 days back. So I thought it is important to show all of you. Now, this case did went for an extraction here about 2 months back. And after doing the extraction, she had a very severe pain. So she, uh, immediately after the extraction, she took some antibiotics, and still the pain didn't go. And after, in this span of 2 months, she underwent a lot of trauma in sense that she visited different dentists. Even the dentist referred to neurologists because they diagnosed it as a post-extraction neuralgic disorder. And also she saw ENT. After that, she even started getting severe headaches. And also she had, because of the extreme stress, she started to have bruxism as well. Now, the systemic, when it comes to systemic history, she was a patient of breast cancer. She was undergoing remission, and she was like, it's been 2 years since she diagnosed, but that condition is much better. Now, if we just have a look at the implant on the right side, it is pretty much close uh, to the mental foramen. So one of the dentists suggested that better we remove the implant because it is compressing the mental nerve. Uh, After that, I saw the CBCT, which was also done earlier, but I didn't really feel that was the case. So we went for a T-scan. Now, T-scan is one of the technologies. I am sure many of you would be aware of that. It is a computerized occlusion analysis. So I will be talking to you on the computerized analysis, how to do it and what kind of equipment we use. But primarily it will be a short presentation. I think Dr. Professor uh, Prafulla Thumati is going to talk in detail about that in the future upcoming lectures. So this was one of the T scans which was done, and just I want you to have a look how the T-scan looks. So this is the T-scan in the multi-bite position. It's basically, and also the pink lines which you see denotes a higher pressure lines. Anyway, we will discuss in detail about all what it looks. But this, after doing the T-scan, it was seen that exactly where the force is getting localized. We did some occlusal adjustments. It's just been 1 week, and some other adjustments were done, and the patient is almost 60% better. So if you can see that, this is a uh, um, what you call a dynamic way and a very objective way of measuring the occlusion. Now, how we can actually use it is there is something called a time delay principle. This was given by Dr. Robert Kirsten, who has been a pioneer of T-scan technology, which says that in case we can prevent the force from happening on the implant immediately, uh, as compared to the adjacent teeth. For example, when the patient is closing his mouth, so if the natural teeth touch first and there is a time gap of about zero point 0.4 seconds in the implant touching, it can lead to a lot of reduction in pressure on the implant. Why? Because the natural teeth have the excuse me, natural teeth have the periodontal ligament, so the teeth can go in by almost about depth of 5 to 25 microns as compared to, 10 to 25 microns as compared to 5 to 7 microns when it comes to the implant. So if we can use this time delay principle, at least the pressure on the implant would be prevented, and also there will be less bone loss and less breakages of the prosthesis which is there on the implant. Uh, Now, occlusion, we'll just talk a little bit more about the occlusion and what all are the shortcomings, what we are having, and how we can use the technology. So basically, I am sure all of us, or majority of us, are using the articulating paper And what are the limitations of that? Articulating paper can actually show where the contact is, but it cannot show with how much force or where exactly how much pressure is being put. And also it so happens that when a person is biting on an articulating paper, actually the articulating paper can pierce through the tooth surface, and there may be no mark at all. So where are we? We are actually lost with this. So um, you know what is the another myth surrounding the articulating paper is that the size and the color will illustrate whether there is high or low force. So let us see what the research says. Now this research was done by Dr. Kirsten and Professor Radke. Now if you see this picture, the red mark which you see, which is the darkest, it seems that this is the strongest contact, but which is not the case. So actually the research showed that only 14% of the time uh, the big paper mark actually tallies with the kind of force which actually the tooth is having. So you can see how much wrong information we can get. So this you can see in this picture. This is the corroboration with the T-scan, and you can see where the lightest or smallest dot is of the articulating paper. There is the maximum force, and the strongest dots have very minimal force. So all I would like all of you just to see this picture and just decide in your mind which is the strongest contact as per you. Just have a look at this picture. Now if you ask me, seeing it as a dentist, I would say maybe 3 or 4. But let us see when we corroborate this with the T-scan, what does it show. So you can see here that the pressure at the point number 4 and 5 is not so much, but on the contrary, have a look at number 1, where the maximum pressure is there and the size of the dot is so small. So you can see how easily we can be misled by the articulating paper. There was another study which showed that 86 to 87% of time the dentist shows incorrect contacts. Now there was another study done which would show the relationship between articulating paper mark size and percentage of force. So this study was done by Dr. Kadir, and this was actually, I went to South Korea when she was doing this study, and it showed that largest paper mark in each quadrant matched with highest force only 38% of the times. And another study was done by Dr. Robert Kirsten. He gave a 6 set of photographs to 295 dentists and asked them to pick the most and least forceful contacts. So you'll be surprised that only uh, less than 41% of the times the doctors were correct. So what was the conclusion of the study? It said that we should not assume that size of paper mark can actually predict the amount of occlusal load. And neither when we use articulating paper, we see equally sized or markings on the adjacent teeth. There it doesn't mean that it represents the equal load. It may represent different loads actually, and that we can actually objectively see on a T-scan. So I'll show you some more pictures of the T-scan. By the way, just I want to tell you that I am not on any financial obligation, neither from any T-scan, neither from T-scan or any other company. So this is pure my observation, and of course I am just presenting the research, and neither I have taken for this presentation anything, and it's just purely for educational purpose. So continuing, what we routinely miss when we are not objectively measuring the occlusion: force, pressure, and timings. Now what do I mean by that? I'm just going to show you in the presentation. Now all of us are so actually the dentists are they are always in quest of knowledge, and we are doing so much, and we are using so much technology. You see, we are using intraoral scanners and so much stuff which I am sure you must have seen, the digital dentistry. So still we are actually banking on the analog methods to measure the occlusion. So I think the need of ours is to shift from analog to digital evaluation. And how do we do that is by the use of this technology. So what is a T-scan basically? It's basically a pressure measuring device, and it's a digital occlusion analysis system which has a patented USB handle and a proprietary software. So basically what it does is it uses the very thin uh, electronically charged mylar encased recording sensors, and you will be surprised that it records the occlusion dynamically at 0.003 second time intervals. Now it would also determine the kind of information what we get from this technology is amazing, and it would tell us, it would show as a color graph where the maximum forces are there, where the timings and the sequences of tooth contact, location and mapping of contacts can be done. Like for example, which tooth first touches first, which is the last, and where is the center of the force, and what, and the information what we can get, I will just share with you in coming slides. So here you can see this is the how the T-scan actually looks like. This is the sensor, which is a very thin sensor actually. It can be used in an individual patients. You can use it a couple of times, but in case the sensor, you see too much markings, it can lead to a faulty reading. So you have to change it. But in general, one sensor is good enough for a couple of readings. So how do we read a T-scan? Again, you can see this video. Uh, if you notice, uh, on every individual tooth, you can see the percentage of forces, and then you see the white lines, which are the lines which are coming up again, which would show the kind of forces on the individual teeth, and also it shows the balance. What is the amount of force on the left side and what is on the right side? Also, information which you can get is which is the first tooth which has contacted, and how long is there between first and second contact, and whether it is forceful or not. I don't think so we can get this information from the articulating paper. So these are the four aspects: timing, distribution, excessive force and balance, which we can see. Now timing is, like for example, if the contact on a particular tooth is much more than the stipulated timing, it represents a higher load and it can lead to the breakage. Distribution is how much there is distribution of force on each and every individual tooth. Excessive force, we saw how it shows on every particular tooth if there is an excessive force in the form of a graphs. And the balance is from the right and left side. uh, let's say for example, if the patient is biting, and the balance would show 30% on the right side and 70% of the left. So we can actually gather all this information in real time. And this is how it looks like. If you can see, uh, the on the left side there is 52.3% of the force, on the right side it is 47.3%. So this can show how much balanced the occlusion is. And on the individual teeth you can see the force multipliers. You can see the lines in the pink, which represents a excess load, and then the lesser load are lines in yellow and blue. So, and at the bottom, you can see there is a graph. Now, what does that graph means is I will just explain you. So there are three things which we can see: the center of the force, force outliners, and graphs. So what I mean by that? So if you can see the black line, it denotes the total force changes throughout the entire scan. Red line would show the changes on the right side of the arch. Green line would show changes on the forces on the left side of the arch. And the degree of separation would indicate the quality of occlusal balance. Now here there are another four lines A, B, C, D. A would denote first contact in closure, and B line shows maximum static intercuspation. C denotes excursive commencement, and D uh, makes complete bilateral posterior disocclusion. So, my dear friends, the thing is, this information we can really have objectively on our screens when we do this, and we can keep our records for the future use as well. Now, when we use a T-scan, we record multiple bite positions. For example, the first position to record would be a multi-bite position where the patients are supposed to bite multiple number of times, and it shows graphically. then we take a left lateral, then right lateral, and even the protrusive movements. All this can be objectively recorded. So this, you see how the multi-bite scans look like. So all this information we can decipher from there. Now, this is a very big learning curve. Actually, this presentation was just to give you an idea how actually the scan works and how it looks like. Everybody has to undergo through a learning curve. I am sure all of you are here to, learn. And as we go, probably we gain more knowledge, and probably we can make best use of the technology. So another thing what we can have a look here is there a good or poor closure strength, or is there a struggle to get the maximum strength? For example, there is any interference which is preventing the closure in the maximum intercuspation position. So this, you can see it's a good closure strength. The graphs are in straight line and the separation is appropriate. When you look at multiple number of scans, you can decipher this information. And now here, if you see in this particular scan, the lines are not straight. It is going wavy, and that indicates that they are not closing in a proper position. Now, what does another very important information which is available from here is center of force trajectory. Now you can see there is an icon in the center which would represent the change in force from first contact to the maximum intercuspation and during the excursions. Now the center of force will move towards the higher force, and if you remember the case which we discussed, the center of force trajectory actually showed where exactly the force is ending and where there is maximum force. So we could actually identify, and that is the beauty of this, that we can really identify. If you use, let's say, articulating paper to identify, okay, you can see that, but you cannot be 100% sure whether it is correct as shown in the research earlier. So what does center of force tells us? It basically, the information what we can get from there is that the shorter is it in length, the more bilaterally simultaneous contacts are there, and the more center is it along the midline, the more bilaterally balanced the occlusion is. If we see that there is a wavy pattern or the pattern is not correct, it would ring a bell that something is not right. And finally, these force outliners which you saw in the earlier picture, these are the lines which are in the red and pink, which show the maximum forces, and we can easily adjust that. And after doing the adjustment, we can again take a scan and then probably understand that now the occlusion, there is no excessive occlusal force. Now here, just one more point which I would like to add, that some of the dentists would argue that even after using the T-scan, we have to use articulating paper. That is correct. That is, we use it just to corroborate our findings and to exactly find where to actually do some minor adjustments. But then these are used as an aid, not to diagnose. So that's the difference between that. So what is the clinical relevance? Relevance means these outliners, what you just saw, they represents the forceful contacts, and that can be a reason for tooth pain, damaged dental materials, cracked tooth, recession, or abfractions. Now even as in a routine dentistry, let's say many of the patients come to us, I'm sure with all of us, which say that filling suddenly broke, or there is a sudden tooth pain, unexplained tooth pain, or damaged dental materials. So we can just do as a routine screening also and find out where exactly the issue is. I remember when first time I went to US, suddenly, I don't know because of what reasons, I developed some pain in my tooth. It so happened when I actually went for a T-scan, and I did my own T-scan. I was surprised to see how accurate it was. So as I just explained you, we can correlate the contacts. We can actually corroborate from the T-scan. If you see these contacts, these will exactly show where the forces are, and that's how we can really identify all of them and try to treat. So what are the advantages basically of using it? It will, of course, dynamically show, and we spend every dentist, in fact, is very passionate about their work, and they spend a lot of money, time, and energy. And if suddenly something goes wrong, your unfortunately the credibility also comes to line. Even sometimes there is no fault of us, but still it happens. But when we can objectively do it, why not? So this can actually help in preventing all those breakages and fractures, and also protect the implants, and because it accurately pinpoints what is the occlusal force overload. So it will in fact minimize the restorative material damage and also the peri-implant tissue damage, which is, I think, the need of the hour. In Dubai, we are charging quite a bit, I think, as compared to uh, let's say in India for an implant. And if when we are doing so much hard work, we are charging so much, we don't want our work to fail. So all the more reason that we make use of the technology to prevent any sort of complication or any issues. So this just I think this is the last slide for the T scan. We can actually make use of other technologies. Like for example, when we use a T scan, we can corroborate uh, the use of EMG to measure the resting and functional EMGs. For example, whenever there is a occlusal discrepancy, the muscles go into hyperactivity, and that's one of the reasons of bruxism as well. So we can easily identify which masseter muscles or temporalis muscles, whatever they are in hyperactivity, and whether they are working in unison or not. And this can all be corroborated along with T-scan data. I think Professor Thumati would explain you in more detail when he takes up his presentation. And this is really, I was really fascinated when I see all these things. Last year, again, I went to US and there was a conference and we had a chance to work on everything, right from joint vibration analysis to range of motion jaw tracking. It has a great potential when it comes to TMD cases. And I would strongly encourage you, at least you have the information so that you can really increase the level or enhance the level of the patient care. Uh, with this, I come to the part 2 of my presentation, which is use of another technology, which is the dental lasers in managing the complications pertaining to different phases of implant dentistry. Now, dental lasers are, as you know, is a wonderful tool to be used when we are using the implant dentistry. It can really help us in managing them really well. But before we actually discuss it, how to manage it, it's really important for you to understand very basic concepts, just a few slides. And the most important thing here, which I want you to understand, is that the different lasers have different purposes. And when we know exactly in what situation what to use, it would make our life much more easy and will really dramatically increase the success rate. So definition, I'm sure all of you know: light amplification by stimulated emission of radiation. Uh, it is is the characteristics are: it is high spectral energy, it has high spectral energy. Now, what do we mean by that is that it is high in the electromagnetic spectrum of the radiation. So that's why it is called high spectral energy. And the most important aspect of laser dentistry is monochromatic. That means it's a single wavelength. And that property of single wavelength leads to the selectivity. That means each particular wavelength of laser can act only on one particular tissue or two tissues, so that uh, we can actually focus, or we know where to use what. So basically, these are the following wavelengths used in dentistry: diode laser, erbium YAG, and CO2 lasers. These are the commonest three lasers which are used in dentistry. Now, this graph really, if someone can really understand this graph, I think half of the problems are over as long as the use of lasers are concerned. Now, if you see here on the right side of the graph, CO2 lasers, and there is erbium laser. Now, this white line, what white graph you see is water, and the yellow is hydroxyapatite. It is actually written in German because I did my education from laser education from the German institute. So that's why we have this slide. So you can see here that carbon dioxide, CO2 laser, and erbium laser is absorbed maximum in water and hydroxyapatite. And here, if we go slightly move towards the left side, you can see the green, the yellow and green, sorry, My apologies. Sorry, the yellow and the green light. Uh, sorry, the green and yellow lines, they represent hemoglobin and melanin. So that means the diode laser and ND-YAG laser is absorbed maximum in melanin and hemoglobin. So this would define how we can actually use the lasers. So uh, there are different wavelengths, as I just mentioned to you, which are used in different situations. I just need you to understand this because this will help in using the correct laser in the correct kind of area where in the implant dentistry where we can get the maximum out of the laser. So if we see 810, 940, 980, these are the different types, wavelengths of the lasers which are used. And 980 nanometer is absorbed at a higher rate than 810 nanometer. And that is the reason why it is potentially more safe to use around an implant. Now we have our concern here that the laser should not damage the implant's surface. So uh, if we use a laser which is absorbed maximum, so that means absorption, more absorption means less dissipation of the energy and less collateral damage. So that's why when we use this particular laser, uh, it is absorbed at a much better rate and gives, we are not worried that it will be absorbed in an implant and it will lead to some issue related to heat, because diode laser is a is a laser, thermal laser. The only disadvantage is it is bit slow because it is a thermal laser. That's why there is whenever we do a procedure, it might be little slower, especially more when the soft tissue is more thicker. Now let's talk about ND-YAG lasers. These lasers operate at wavelength of 1064 nanometer, and these are poorly absorbed in water and readily absorbed in hemoglobin and melanin, and that's why it can really penetrate to a depth of 4 millimeters. So it increases actually the potential of damage to soft and hard tissue as well as implant surface. So many of the studies have reported that it can produce cracks and craters, and it is not really safe to use in implant related treatment. Now let's talk about CO2 lasers. Now this wavelength 10600 nanometer, it is highly absorbed in water and collagen and hydroxyapatite. And even this laser and erbium lasers, both are highly absorbed. So that is the reason why these lasers are used in hard tissue. That means we can use it to remove the tooth structure and also the bone as well. And this is extremely absorbed in water. Uh, and that's why it is very efficient for soft tissue vaporization. Now this has advantage, it can be used for both hard and soft tissue. Now there is another factor that these lasers offer strong hemostatic and bactericidal effects and contain minimal scarring. Now we can use this laser when we need a proper hemostasis. Now there may be certain situations when we need that some kind of bleeding should happen. I will explain you that kind of indications. In those cases, we don't use CO2 lasers. We would prefer, when we prefer that a bleeding surface should be there following our procedures, in those cases we use erbium lasers. These are the preferable ones. And because of the minimal penetration and maximum absorption, there is reduced thermal damage. So basically these are safe to use around implants because energy is absorbed in water and not in pigments. So erbium lasers, they have a wavelength of 2940 and 2780, and they are again highly absorbed in water and hydroxyapatite. So that's why since it is absorbed in water, it is used to safe around the implants. Now these are uh, the few important points which I will be discussing now, how to actually use the lasers to prevent the complications. Now, let's say when we are about to insert an implant, we need a surgical site decontamination. So we can use either of the three lasers to decontaminate the site. And actually, alternatively, what do? We ask the patient to use a mouthwash, or we can use a betadine solution or a gel for a local site decontamination. Some of you might argue that what is the need? Because again, when we use a drill, again it gets decontaminated, but it is always better to decontaminate a site, and we can even do it repeatedly in case the need be, in case you feel that something is compromised. So this is a very safe and effective way of doing it. Now, another important aspect is decontamination of the extraction site, especially when you are placing the immediate implants. Now, normally what do? We curate the site very properly and make sure that the site is clean before we do the immediate implant placement. Now, let's say if we are using erbium laser or CO2 laser, we are sure that, more or less sure that the decontamination is really going to be good because of the properties of the lasers. And here, one important point which we just discussed, either we use erbium or CO2 lasers. Now, in this situation, when we are doing placement of doing an immediate placement of implant, we would like to have a little bleeding surface. So in this case, erbium lasers, because it uses water spray also along with its properties, so we would prefer a bleeding surface, and erbium lasers can do that. On the contrary, CO2 lasers, they leave a little bit of carbon charring. So hemostasis is very good in lasers, but we need a bleeding surface. So erbium lasers might be a little bit more preferred to CO2 lasers. I hope I am clear in this. Now, let us say in a situation wherein a patient is taking anticoagulants. Now, as we all know, bleeding might be an issue for those patients, and nowadays we ask patient not to stop if the patient is really compromised. In that case, when we use a laser, first thing is that the complication of hemorrhage may be under control, and in fact, the decreased bleeding will lead to a better visualization, and hemorrhage control will be a less of an issue. So we can do a better job when we have a more clear field, and of course we are not worried about the bleeding part. Also, when sometimes there is a bone which during the time of implant uncovery, we can use to remove the bone with using the laser. Now, what happens is the main advantage here is that we can use actually the same instrument or same laser to actually remove the bone. I'm talking of erbium and CO2 lasers, removing the bone as well as taking care of the soft tissue, which is an additional advantage. So the most common complication what we face is the peri-implantitis, and this is, I think everybody would be facing it sooner or later because the kind of number of implants which we use. Now, in a conventional therapy, what we do non-surgical debridement. We use curates, especially special curates, and antimicrobial therapy, antibiotics, because primarily it is a bacterial infection, and then we open it surgically and decontaminate the implant surface using various chemicals, chlorhexidine, or there are so many, minocycline, doxycycline, whatever we want to use, and then we can even graft the bone. So this is a conventional therapy. So how does it compare when it comes to laser? Well, a lot of studies have been neutral on this, but a lot of studies have actually said that the laser has a distinct edge. One reason, of course, is that debridement and uh, debridement. Sorry, just 1 second. I think there is something issue with the batteries. Just let me check, please. Just a second.
All right, participants, in the meanwhile, I'd request you to kindly post all your questions. Let's keep all the questions for the question and answer session. And I think we can cover them all. And I'm sure Dr. Shallen would love to cover all your questions during the question and answer session. Till the time Dr. Shallen
Uh,
is back, let's quickly put all the questions in the Q&A box only. Thank you. Over to you, Dr. Shallen.
Sorry, my apologies, sincere
No
apologies.
worries, sir. Thank you very
I
much.
had plugged in, but I forgot to switch it on. So sorry about that. So decontamination and debridement are accomplished by a single instrument in case of a erbium laser. So I just want to make one comment here that, let's say when we have, I'll just give you a small example. When we have a case wherein we are doing a root canal, for example, so we are using a solution to debride the whole area. But actually in lasers, we have something called a circumferential tip, wherein it would penetrate a depth of almost 1,000 micrometer inside the root surface after doing a normal debridement. And then we are more or less sure, at least, the because the laser energy is absorbed in pigment, so bacterias are taken care of. So in this situation also, the kind of debridement and decontamination which we can achieve with laser is, I think, phenomenal. And if we are able to really access that area. So in this situation, when we compare the erbium versus CO2, so CO2 laser, when it used, it causes carbonization of bone, as I just mentioned. So it results in hemostasis, uh, uh, but there is no bleeding. So in this particular situation, let's say when we are treating a peri-implantitis, bleeding has to be re-established. So in that case, when we need bleeding to be re-established, again, RBM laser might have an edge in this. And when it comes to, let's say when it comes to doing a surgery with a clean incision, we would prefer CO2 because the hemostasis is really good. Now, what is the protocol? How do we actually treat is, now in early or middle stages of mucositis, when there is just loss of bone at the cervical aspect, surgical, using the laser and energy around the implant would be really be sufficient. In case it progresses from mucositis to peri-implantitis, now there may be a laser assisted surgical approach wherein the incision might be raised and then bone grafting can be done. Now, with either approach, actually, the higher success rate is there, and in a few studies, it is proven that it is much more as compared to the traditional methods. So here, when we are actually using the lasers, we can actually give an incision with the same laser. Then we can remove all the granulation tissue. We can do the decontamination of the laser, and also uh, control the bleeding, or in case we want a bleeding surface, we can do that. And when we are able to control the bleeding, we have a better visualization. So in other words, uh, we have all the positives. And of course, learning curve is one thing which is, I can say, which you all need to do when you are using the lasers. Otherwise, with that I am sure holds good with every technology whatever you are using. So once we are able to understand this aspect, that this particular laser is going to be used in a particular situation, we are good. Only thing is, majority of, I don't know, but this is my personal feeling that because of the very high costs, exorbitant costs involved with the CO2 and the RBM lasers, so it might be a deterrent, but in the long run, whenever the technology is available, it can be really made good to use. So this is one of the cases which I want to show you, wherein on the this was a second stage in implant recovery. Uh, this patient came for placement of an implant. This was a 49 years old healthy female. This was just to show you how we use for implant uncovery. This was a pre-op x-ray. We did the extractions, and then this was one of the implants was opened surgically. The other one, we use the laser. Now, if you, important thing which you need to understand here is uh, the the direction of the laser tip. Now, it should not be pointing towards the implant. So you have to, let's say, put it at a 30-degree angle. And when we use a diode laser, it should generally be used when the soft tissue thickness above the implant is, let's say, between range of 1 to 2 millimeter. If it is more, then I would rather prefer using the other lasers, because one thing is it slows down the process. It's a thermal laser, so what would take seconds for a CO2 laser would take, let's say, minutes for the uh, diode laser. So this is immediately uh, after the procedure. This is after placement of the implants, sorry, after putting the healing caps. And this is the healing post-op. After 1 week, you can see how clean and clear it is because of the kind of sterilization uh, achieved, decontamination, sorry, sterilization of the area achieved, and a clean cut was there. This is before the crown placement. This is after placement of abutment and final prosthesis. So here, what are the other advantages which we can get here is that uh, let's say when we use a BP handle to uh, do the uncovery, the bleeding can actually interfere with the impressions. So normally what we do, we delay it for a period of 1 or 2 weeks before the impressions can be taken, so that it doesn't hamper the accuracy. So when we use the lasers and we achieve the good hemostasis, we can take the immediate extraction, immediate impressions in case you need to do the prosthesis. Uh, Now, as I just mentioned to you, when we do a soft tissue cutting with the lasers, if the laser tissue is more than 1 to 2 millimeter thick, you can use CO2 lasers because of the speed. And the diode lasers, in fact, has a very good advantage that they would maintain a temperature profile within the range of the bone and the implant. So you don't really need to worry that you will damage the implant surface. And also it doesn't causes any tissue shrinkage that can affect the aesthetic outcome. So basically we can actually, when we have certain implant systems, this is by the way one of the very important use of the lasers, what I'm just
Dr.
discussing
Shallen, I
as
request you to kindly wind up your presentation in the next 5 minutes.
yeah, this is the last slide actually.
Thank you so much, Doctor. Please continue.
So this is a very important indication uh, when it comes to using the soft tissue, because in some implant designs, the characteristic results, the results are a large volume of the soft tissue, which in case you don't sculpt, it can lead to the false pocketing formation, and also the impression taking becomes an issue. So uh, we can actually reduce the what you call the thickness of the soft tissue in order to prepare a proper implant prosthesis with a proper emergence profile. And also, if we have a clear visual field, it is really important for the lasers, which I'm sure are the excellent tools. So as a last slide, as a take home message, I would say that once you are really very well versed with what type of laser to use in what situation, you will actually increase the level of your clinical work, and that will be very satisfying to you when you get what you are really looking at. All of us are so much into the technology, so when we embrace this technology, it will really improve the patient outcome, and when we do a better job, it will definitely reduce the complications if they are used judiciously. Thank you very much.
All right, ladies and gentlemen, it's now time for us to start with the question and answer session. We start with the first question. So, can we decontaminate the implant surface with any laser, or can we only decontaminate the soft tissue surface?
Okay, we can of course decontaminate the implant surface, and that is the reason, that is the main advantage of the laser. As I just mentioned in my presentation, with a single instrument, we can give an incision, we can remove the granulation tissue, we can remove the necrotic bone, and we can decontaminate the implant surface. So that's the USP of using a laser.
Thank you so much, sir. Thank you for answering to the question. We move to the next question. Is P-scan available with a CBCT machine, or is it a separate entity?
No, it's a completely a separate entity. CBCT is basically a imaging tool. And this is a computerized occlusal analysis, T-scan. It's a separate machine.
Thank you very much, sir. Next question. Sir, what laser would you suggest for using in case of LANAP, a LANAP procedure?
The recommendation in literature is using the Nd:YAG laser.
Thank you very much. What is the cost of T-scan sensor accuracy?
Cost, can you please reframe this question? Cost, or
Jagdish, I request you to kindly reframe your question and
if you're,
tell
if,
us from which country, which part you're joining, because the cost varies on every country and every region wise.
yeah,
Next
because,
question, how to treat peri-implantitis if laser is not available in the clinic?
as I mentioned if you saw my presentation, I mentioned the conventional way of doing it. Now, it depends on what stage the periimplantitis is. If it is mucositis, you can do a general debridement and there is only cervical bone loss. In case it's gone deeper, you have to give an incision, open the flap, do the thorocurettage, remove the granulation tissue, and if the need be, if exposure of threads is there, you have to do the bone grafting and of course the occlusal adjustment. This is the
Thank you.
conventional way of doing it.
Thank you very much, doctor. Next question. If T scan is not available, then how to correct occlusion if any high point is there?
So this is a very, again, the whole crux of my presentation was this only, that we have been doing, and the dentistry is really forgiving, and we should salute the our oral cavity for that it is so forgiving. So when it comes to more complicated cases, I would say if you can embrace the technology, T scan is very good. Otherwise, we use the various thickness of articulating paper to do our general dentistry day-to-day's work. But I would really, as you saw, how accurate we are when we use articulating papers. So this is one thought which you need to ponder upon and decide what kind of dentistry you want in future.
Certainly, doctor, certainly. Next question. So can you please name a few special curates that can be used safely to debride implant surfaces?
So basically, the materials which the curates which come are of different, not the regular stainless steel or the Gracie's curates which come. These are the special curates which you can get from all the dealers.
Thank you, sir. Friends, we are open to a question and answer session. I request you to kindly post all your questions. Next question. So what is the difference in red and blue articulating paper and their indications?
Okay. Uh, Basically, red and blue is a very arbitrary term, I would say. Now, there is variation in the thickness of the articulating papers. For example, the articulating papers which you use for your crown and bridge or denture work are much different than what you use for the implant surfaces, because in implants we use the minimum thickness articulating papers, because as I just explained you, the implant would just go about 5 to 7 micron inside, because it has not got the periodontal ligament. So we need to identify, if you need to identify prematurity, a thicker articulating paper would not do in implant. But when it comes to crown and RPD work or complete dentures, you can easily use that. So that is the main difference, the thickness which you have to see and what indication you're using.
Thank you very much, sir. Next question, and I think this should be the last question. Can T-scan help in bite registration during full mouth case?
Uh, I would not say registration, but definitely I would say that it will, when you give a full mouth prosthesis, it can really help in balancing that. And that is one of the major indications. When we are doing so much restorative work, it can be easily be used. Now the technology is enhancing. Now you can even, superimpose the digital impressions, what you can do with T-scan. And even so, I I think last year when I was there in Bali in a conference, they were working on, I think they have already worked on putting the T-scan software in the digital smile design. So there is no dearth of what you can actually do. This is the best way of, having what you call visualizing dynamically the occlusion. So definitely you can use this in this when you use a full mouth prosthesis.
All right, sir. The next question says, what is the price of T-scan? Ma'am, I would request you that it's very difficult for a speaker who's based in Dubai to tell you about the cost. If you wish to know about the cost, you need to get in touch with the local distributors. You can message us, DentistChannel.Online, and we will help you to connect with the right person when it comes to the cost and the marketing involved. Dr. Shallen would certainly not be able to tell you about the exact cost, but an approximation cost is what Dr. Shallen can give you. So Dr. Shallen, can you tell us an approximate cost of the T-scan equipment and the device?
I am not very sure, but I think when I bought it was somewhere in the range of 12 to 14,000. I'm not 100% sure because I bought it sometime 3 4 years back. So I think that now maybe the upgrade version has come, so probably the cost might be more. But I am really not sure about this because normally we don't procure directly. We just, yeah.
That's right. That's right. So, friends, it's very difficult for us to tell you the cost of a particular equipment, device, or an implant or the implant system.